although you may see a lot of other types of trauma out in the field, it's not surprising that sometimes you come across patients with neurotrauma and how to manage those patients in lieu of not having a neurosurgeon immediately available. And typically, neurosurgeons are a rare bunch, and sometimes they're not always available to help with people with multi-system trauma. So without further ado, I wanted to give you a few of the essentials of how we deal with neurotrauma. I have no disclosures, no conflict of interest. There are really three phases of neurotrauma. This also goes with spine trauma as well. There's the initial impact or the initial traumatic injury. And I can give you this PowerPoint presentation later. If you send me an email, I'll leave my email address. So all the slides will be given to you anyway. But the initial impact is the major problem. It causes the major concussive injury to the brain, and it could be it could vary in the types of in its severity. The secondary injury is where our management or a physician's management is most clinically important, because the initial impact, it could be devastating. But for those people who survive the initial impact, it's the secondary injury that is the post injury downstream effects of what just happened is the most important. And then sometimes patients, no matter what we do, are just going to not do well, and that's the third phase of the neurotrauma situation. Where we can make an impact is really that secondary injury phase. So you all know this, but the basics are just like any other type of neurotrauma, ABCs. When you're out in the field, you have to pay attention to the simple tenets in trauma, and that the brain needs oxygen and it needs circulation. And we'll talk about each of these different things in detail further down the road. But hyperventilation, for example, actually helps cerebral autoregulation so that you can decrease intracranial pressure. And sometimes it's important, just like anything else, to resuscitate the patient and ensure that they have enough blood flow to the brain. And when it comes to spine injury, specifically cervical spine injury, which is also very often concurrent with neurotrauma in 60–70% of the cases, you have to make sure that the cervical spine is also paid attention to. You all know this, but as when you first see a patient with neurotrauma, if they're awake and talking to you, or if there's information that you can glean, these are the most important things of information that you need to glean from the patient or from the family or from whoever you can find at the scene of the actual trauma. And sometimes this is very hard to get information, but these are some of the most important things, because what you're going to administer to the patient to make them survive their neurotrauma is very, very important or very based on some of these things, and we can often make a decision based on those things alone. The neuro exam, a lot of you know the neuro exam, but there are very specific, easy things that you can do in the field. The first is just to palpate. You can take a look at the skull, take a look at someone's head, palpate the neck, palpate deformities in the scalp. They will, if they have neurotrauma, have the classic sign of raccoon eyes or blood, or look like they have a bruised eye, petechial ecchymoses, periorbital ecchymoses. Often, if this neurotrauma is severe enough, they will have CSF pouring out of the ear or nose. And sometimes a patient may not have any outward signs of clinical neurotrauma, but may have a seizure, and that often gives you an indication that something bad is happening, especially in the setting of multi-trauma. The one important thing that the only time I ever use a stethoscope as a neurosurgeon is to listen to people's carotid arteries and the vertebral arteries. And sometimes if there's a carotid artery dissection, which is one of the most important things that you see in cervical trauma, where you don't pay attention to as much, they may have a really bad cervical fracture, but the one thing people miss is a dissection of the carotid, which can be, if you have enough trauma to break the bone, there's no such thing as, there's not enough trauma that you can get to actually dissect the carotid artery. So that can be often concurrent injury that can be missed. And one of the most important syndromes that people miss with carotid artery dissection is Horner's syndrome, which is where the pupil is dilated, they have a ptosis with one eye, and they may be awake and talking to you with a C4 vertebral body fracture, but little do you know that at that level, that's where the carotid bifurcation is, and sometimes they've dissected that eye. So in a patient who's awake, talking to you, but with a dilated pupil and some ptosis or a drooping eyelid, that can be the first earliest manifestation of a dissected carotid. Very important not to miss that. The neuro exam, we have a GCS scale, and that is very straightforward and easy for us to use. It gives us a way to communicate with each other, so that we don't make mistakes. So if I'm communicating to a if I'm at a rural site trying to communicate to the neurosurgeon in the city, that person is going to want to know this type of information, just so that there's a equivalency in the communication. The Glasgow Coma scale is built up in 3 different parts: eyes, motor, and verbal, and those seem to be the most important clinical correlators to clinical issues with their brain or spine. Eyes basically get a sense of whether the patient is opening eyes, is able to respond to voice or to pain, or not opening their eyes. The motor score in terms of how much movement they can provide, whether it's anti-gravity or not, and whether the patient is actually talking to you, and how comprehensive is their sense of speech. So based on that Glasgow Coma scale, patients are ranked. The maximums they can get is a 15 if you're normal. If people have mild concussive injuries, you can sometimes miss that, but it's often in that 14 to 15 category, almost normal. Maybe they're confused about what they are. That's a GCS of 14. The moderate category, I think, is the most dangerous, because that's where you'll see a multi-trauma patient and you think they're doing okay, but they're just not right. They have problems with either weakness in one of their extremities, they have a problem, they seem to be in so much pain they don't open their eyes, or they don't seem to be making comprehensive speech or be able to talk to you in an appropriate fashion. That is one of those most dangerous syndromes where they are doing okay, but those will deteriorate. And if those deteriorate, 75% of them will have some form of intracranial hemorrhage, whether it's a subdural hematoma, an epidural hematoma, or some form of bleeding into the parenchyma. The severe GCS, that's less than 8, those patients will inevitably have multisystem trauma, and 5% will have actually cervical trauma. So if you see a patient who is very severe in GCS and you have no imaging capabilities and you don't know what's going on, fear cervical trauma and get that patient into a collar or stabilized as soon as possible if you just suspect it. And that's why I encourage people who are at least in the moderate to severe category, if you're going to get head imaging, get neck imaging, or vice versa. If you're going to get neck imaging, get head imaging at the same time. There are several patterns of neurotrauma, just a way to think of them. The concussion is the easiest one to think of. That's the low impact injury that you sometimes see in sports or in minor vehicle accidents, motor vehicle accidents of minor velocity. Contusions actually have bleeding in the brain, where the concussion has caused enough damage to the tissues that cause some bleeding within the tissue. The epidural hematoma, that's the layering of blood on top of the surface of the dura, and that can often present in a delayed fashion. That's also a very dangerous sign, where someone has an injury, they've lacerated the middle meningeal artery, and downstream effects are they're doing okay, but the rapidity in how that bleeds can cause a problem down the road. The subdural hematoma you've all seen before in either training or at some point during your careers. The subarachnoid hemorrhage is rare, but also can happen due to traumatic reasons, and that is due to impact and contracute injury that will lead to bleeding within the arachnoid space of the brain. And the one that is the hardest to treat and was only kind of discovered, as you were, or rediscovered in the 1970s, is diffuse axonal injury. If you look at the brain, it's not one density structure. There is different densities to the brain. The density of the gray matter is different from the density of the white matter, which is different to the density of the brainstem. And if you can imagine, if you spin something that has different densities, the gray matter is going to spin at a different speed, the white matter is going to spin at a different speed, and the brainstem will spin at a different speed. Because of those differences, patients can have a normal CT scan, but they've sheared all their neural pathways because of that different angular velocity of all those things. And that's why diffuse axonal injury is very hard to diagnose and treat, because the patient is comatose but doesn't have any big signs on initial CAT scans. It's really the MRI scan that can sometimes pick that up. And if you don't have access to an MRI scan, you won't pick up diffuse axonal injury that easily. So I know a lot of you are orthopedic surgeons here. So these are some of the things where Jens and I obviously go back and forth with some of the multi-trauma patients, but the things where the neurosurgeon will trump the orthopedic surgeon is if patients have an intracranial mass lesion, that blood clot in the brain, an elevation of intracranial pressure, and we'll talk about what that means, and decreased level of consciousness. So I know that some patients can be very sick and they can have very bad fractures or very bad injuries that need to be urgently fixed. But if you have any of these three signs or all three signs, that can be obviously a contraindication for orthopedic surgery to happen first ahead of neurotrauma, or at least the way I've been trained, there's no reason for two surgeons not to do an operation at the same time on a single patient, while the orthopedic surgeon or general surgeon is helping with the body. The neurosurgeon can be at the head of the patient, dealing with whatever intracranial issues the patient may be having. So intracranial pressure, I mentioned it, I alluded to it. Sometimes it's a very complex phenomenon that's hard to understand, but the basics are that the skull is a box and there's not enough room for more than just brain, cerebrospinal fluid, and the blood that's running through the arteries and veins. And as you have something else, a mass lesion, such as a hematoma or a blood clot, the brain can deform to a certain extent, but there's a breaking period where there's not enough space for any of the brain tissue concurrently with something else, and this can be rapid. So initially, you can have a patient who can compensate pretty well, doing pretty well off the initial impact of injury, but as they get worsening signs of symptoms of ICP, you'll notice it because the patient will have an increasing size of mass lesion, and that is really the crux of intracranial pressure. How to interpret it? Now, you probably interact with neurosurgeons and they'll say, the intracranial pressure is too high. Well, how do they make that determination, and how do you as orthopedic surgeons understand that going forward? Sometimes what will happen is a neurosurgeon is so busy or in a multi-trauma situation where there's many casualties or a lot of issues happening with the patient, they'll put an intracranial pressure monitor in and leave you alone. They'll be like, okay, I got other people to take care of. And you as the orthopedic surgeon, general surgeon, will have to understand what it means to deal with an intracranial pressure when you're managing the patient on your own. The neurosurgeon is now out of the picture. He's put an intracranial pressure monitor in. How do you interpret that? Well, the intracranial pressure is basically a way to help you determine the cerebral perfusion pressure, which is the CPP. The cerebral perfusion pressure is actually the most important thing. That is what is driving perfusion to the brain, to the neurons. How do we calculate that? It's simple. It's the mean arterial pressure minus the intracranial pressure. So an intracranial pressure monitoring device will give you that ICP number. If you're perfusing the brain adequately, you just have an arterial line, for example, or you calculate the mean arterial pressure, and you want to keep your cerebral perfusion pressure above 60 to keep brain alive. That's in the yellow bar. The way to calculate mean arterial pressure I've just mentioned there, but most people, if you have an arterial line, will provide you with that information. And the goal intracranial pressure, when you're doing orthopedic surgery, when you're positioning a patient, is to keep it below 20. So let's say you're positioning a patient for a surgery, they have intracranial pressure bolt in. You want to make sure, an easy rough guide is to make sure that the ICP is less than 20, or to drive the blood pressure up so that the CPP is greater than 60. You can work on either way. Sometimes it's impossible to position a patient and maintain the ICP less than 20, and if you have to, drive the blood pressure up so that the CPP, the cerebral perfusion pressure, is adequate for that patient. So this is sometimes a more complicated issue, but the only way to manage this is if you have someone who can help you put an intracranial pressure monitoring device in the patient before you do surgery. Other things that kind of allude to a very bad situation are Cushing's Triad, which is an important way to understand if the patient actually herniating. So you'll hear patient's herniating. What does that mean? Well, it's basically the patient will have the clinical signs of hypertension, but paradoxical bradycardia. So if you have a patient who you're seeing in the field and they have hypertension and bradycardia, that's a bad sign. They'll also have respiratory issues where they can't breathe or they have irregular breaths if they are intubated. And these three things are signs of impending herniation. This is the worst situation. This is when if you're uncomfortable, you need a specialist involved. And we'll talk about some easy management strategies when you have this situation, when you have bradycardia, hypertension, and a patient who's not awake or with a decreased level of consciousness. That's a bad situation. So the pupil is often the one thing that it's very easy to monitor outside of the patient, outside of any other device or thing that you have. The easiest way to check if there's any issues in the eye is to swing a flashlight in the eye and make sure that there's consensual responses between left and right eyes, or right and left eyes. Basically, there should be a concurrent response in both eyes no matter what you do. If you have an asymmetry in the eye, sometimes that can be natural, but in the setting of neurotrauma, if it's greater than a millimeter, you have to be concerned of any pathology. I'd mentioned Horner syndrome as a sign of dissection of the carotid artery, where you have a paradoxical pupil dilatation in the setting of an awake patient. In the setting of a non-conscious patient, an anisocoria of greater than a millimeter, or difference in the pupillary size of greater than a millimeter, can be very disturbing. If patients have major cranial trauma to the skull base, they can damage cranial nerve 6. Cranial nerve 6 is the nerve that controls movement of the eyes, the lateral rectus muscle, and that controls the movement of the eye laterally. So if they have a cranial nerve 6 palsy, their eyes will be looking at each other because they'll be weak, or the one eye that's affected will be turned inward because the lateral rectus is not working. Cranial nerve 6 is a really easy way to check if there's skull fracture pathology, because the cranial nerve 6 has the longest course to travel inside the brain, and if there's any sort of skull fracture that has caused shifting of brain compartment, you'll notice that first in the patient, cranial nerve 6. Cranial nerve 7, you'll see that in basal skull fractures. It exits down at the skull base. If there's any trauma to the Bayesian or occiput, you'll notice cranial nerve 7 trauma as well. And that's often seen in the upper cervical region when you have trauma in that region. So typical of what happens in rural medicine is that you may be miles away from a CT scanner, nowhere near an MRI scanner. What do you do? If you have a patient who has neurotrauma, but you're able to get a set of x-rays for their body parts and you can tell they have a fracture, tell they have a C-spine fracture, what do you do? I think last time I was at Sign, I met a general surgeon from Nepal, and he had no access to a CT scanner, and he was asking me, to talk to him about what you can do in the setting of no CT scanner with neurotrauma. X-rays, or if you have availability of X-rays, are usually the best way in the absence of physical examination. Although they're not perfect, they're a great way to see fractures. And if you see a fracture, it is very indicative of some sort of trauma in the unconscious patient. And sometimes you can see clear deformities in the skull, which give you an indication, or you can see widening of greater than a centimeter of the normal kind of connections between the bones in the brain, or a true fracture in the brain. Air in the head is always a bad thing. You should never have air in the head, and you can often see that. One thing that you can tell in adults is the pineal gland, it calcifies over time. Now, our pineal glands, for the vast majority of adults, will have some form of calcium in it, and you can see it on an X-ray. And it usually is midline. The pineal gland is anatomic midline. If you see that it is left or right of the skull, and the patient is unconscious, and you feel something bad is happening, that's a sign that something is pushing the pineal gland to the other side, and that can give you an indication that we need to do something. And obviously, penetrating injuries for blunt force trauma can be seen as metal or debris within the skull X-ray. So, what do you do when you have a patient who you're just not comfortable with managing? You can stabilize their fractures, but you need to get the patient to a neurosurgeon ASAP. Early communication is important, and that's why I hope this lecture is helping a little bit to get that idea that if you are suspecting something bad, time is brain, and time, it's an old phrase, but time is brain. So the longer we wait to get expertise, the longer it can, the worse the problem can be. Mobile phones are texting and video has become like the mainstay. People might not have any other communication at this point other than a mobile phone. If you're greater than 25 miles away from someone who you think will provide more comprehensive management, consider air. If you don't have air, consider obviously ground transport. But that all depends on the geography, the topography of where you live and where you are. And I think the most important thing really I want you to take from the lecture is that the neurological examination is one of the most important things to help you manage these patients. So if anything that will help, I think that aggressive knowledge of doing a physical exam early, especially a neuro exam early, in a setting of someone who has multi-trauma, will help you get these patients to the right place ASAP, or help you manage intracranial pressure issues. So non-surgical treatment, this is something that is very important because these are things that you can do right there for the patient if you suspect neurotrauma. Elevate the head of the bed, or elevate the person's head above their heart. That often, if you elevate them up to 45 degrees even, that will basically reduce jugular or venous return and will improve cerebral perfusion pressure. Sedation helps, and propofol or things like benzodiazepines like Burr said will help decrease ICP because by decreasing the demand of cerebral perfusion or metabolism. If a patient's seizing, treat their seizures. Mannitol has been revolutionary since it was introduced in the 1920s and 30s as a mainstay for treatment. Basically, it is an osmotic agent which drives fluid out of the brain, and when it drives fluid out of the brain, it goes back to that whole concept of ICP and the skull only having so much room. If you decrease the amount of water or fluid in the brain, it will help that ICP curve to some extent. There is a limit to how much mannitol you can give. You can't keep giving patient mannitol; it won't always work. I usually give a patient who has severe trauma 100 grams of mannitol, regardless of their weight, and obviously that will be different for pediatric patients, but where we do it by weight. But for the adult who's greater than 60 kilograms, you can give that 100 grams of mannitol right away. But there's not much more you can do beyond 100 grams of mannitol, and after a while it doesn't work. Hyperventilation, reducing the PCO2 to less than 30 will help autoregulation in the brain. As you decrease the CO2, there is a narrowing of the arteries in the brain, and that decreases the pressure phenomenon inside the brain that can help. And obviously, blood work is very important. One thing that is important for neurotrauma and has actually led to better outcomes is correcting things like hypoglycemia. If patients are on a blood thinner, giving the patient platelets and things like that can also help as well. The surgical treatment of neurotrauma, and we'll do this in the lab today and tomorrow. What do you do if you're by yourself and you know you're 25 miles away, you have no way to scan the patient, the neurosurgeon is not even available, you can't even talk to someone on the phone? How do you fix this patient immediately? For the person who has a subdural or epidural hematoma, this can be life-saving. And sometimes with even patients who have intraparenchymal hemorrhages, can be life-saving. What do you do? So I drew this picture, and it's not that great, but it's basically how you're looking at the patient. It's an upside-down head. So you'll be standing at the head of the bed, so this is what the patient looks like with their head turned. Now, if you suspect pathology on this side, obviously the one thing that limits this procedure is knowing which side the patient has a problem. But once you've decided which side the patient has a problem, you look at the patient, and we know that there are landmarks on the skull that will give us the highest bang for our buck or highest return, and those are the places you want to start drilling a hole. And the idea of drilling a hole is that you have a chance of releasing pressure from the brain. Now, you'll see how easy and how scary it is when we go to lab, but there are certain points. The first point is here above Coker's point, which is in the mid-pupillary line, just behind the hairline of the coronal suture, or just anterior to the coronal suture. The parietal boss back here. Again, if you make holes in the mid-pupillary line, you're always going to be safe, as long as you stay either anterior to the coronal suture a little bit, on the coronal suture, or the parietal boss. The last hole that's very important for if you suspect an epidural hematoma is the one that's right here above the zygoma, because the middle meningeal artery is often injured at that region, and you'll have if you have a large epidural hematoma, sometimes that's the best bang for your buck. Drill a hole there and release pressure. And sometimes if you don't find any blood or there's no problems, sometimes people can have bleeding in the back of the brain, the cerebellum, and you might have to target that as well. Again, if you stay in the midpupilar line in most patients, you'll be fine. And we'll show you how to do that in the lab. This is another picture. I mean, the brain is made, the skull is made of several layers: skin, periosteum, bone, dura, arachnoid matter. Your goal with the drill, when you're drilling through this, is just to get through the inner and outer table of the skull. We have a drill here where it's basically, it looks a bit like this. This is how scary it is. You can get it actually at a DIY store, but it's very straightforward. Whatever you want to do is get a sense of the feel. Tomorrow, if anything, I want to have you get a sense of what it feels like to catch between the inner and outer tables, because as you drill with your hand, you'll notice that you kind of almost get caught and fall into the head, and I want you to feel that. Because once you feel that, you'll get more confident in trying to do this on your own, without worrying about causing a massive problem. Now, the other thing I'll show you in lab is that as you drill, it's not about pressure, pressure down, but just using the speed of the drill to actually drill through the skull and letting the drill bit catch on the inner and outer tables, or outer and then inner tables. It's separated by obviously a trabecular network, and that you can actually sense and feel as you drill through the skull. And again, as I mentioned, these are kind of the rough points where you want to get started with drilling and go from there. Eventually, I think as technology improves and as the technology spreads across the globe, there'll be easier ways to do this without the need for a neurosurgeon to be around. And if we can get the right mechanisms to triangulate how we can look at the brain, either through virtual reality or through using skull x-rays or CT scans to map out someone's brain, it makes it much easier to actually put an intracranial pressure monitor in. And I think people are advocating training general surgeons, orthopedic surgeons who are from rural parts of the world that don't have access to the right surgeons to do this, or people who are comfortable doing this. Training those people to do these things like we're going to do today will really help and make things work out. Thank you. And if you have any questions, I'll take them.